Hello, everyone, and welcome to tonight's Ovarian Cancer Canada speaker series. My name is Dr. Jessica Lawson, and I'm the research coordinator here at Ovarian Cancer Canada. I'm thrilled to be your host tonight for tonight's speaker series, HRD testing in ovarian cancer, what patients need to know. Before we begin, I would like to acknowledge that tonight we are joining together from across Turtle Island on the lands that we now collectively call Canada. We recognize and respect that these are the traditional lands of many diverse First Nations, Inuit, and Métis communities. We commit to doing all we can to encourage the culturally safe care of all those affected by ovarian cancer and related gynecologic cancers, and to use our unique position as a health charity to respond to the calls of action outlined in the Truth and Reconciliation Commission. Tonight, we are joined by experts in gynecologic pathology, oncology, and advocacy who will share their insights and experiences on homologous recombination deficiency, or HRD. Our focus will be on understanding HRD not just as a test result, but as an important aspect of care that affects diagnosis, treatment decisions, and access across Canada. I'm excited to introduce our very first speaker, Dr. Basile Tessier-Cloutier. He completed his training in gynecologic pathology at the University of British Columbia and Memorial Sloan Kettering Cancer Center. He is now a consultant gynecologic pathologist at McGill University Health Center and a principal investigator at the Research Institute. His research focuses on the morphological and molecular profiling of aggressive gynecologic cancers and the development of experimental models. Welcome, Dr. Tessier-Cloutier.
Thank you so much, Jessica. It's really an honor to be here in such a great event and talented speakers. So I will share my screen now. And can you see this correctly? Yes. Okay. Great. Yes. Thanks again for the committee for inviting me to speak. It's so heartwarming to see such a well-attended session, and so let me get into this now. So the objective for my presentation are to describe homologous recombination deficiency, or HRD, and explain the role of homologous recombination, or HR. Finally, we'll discuss the different types of HRD testing, and here are my conflicts of interest. And now, what is HRD? So HRD means homologous recombination deficiency. Now, what is homologous recombination? Well, homologous recombination is one of many DNA repair crews that live in our cells. That's right, repair crews, because we literally have these molecules in our cells that have for purpose to repair the DNA, the damage in our DNA. Here I sort of depicted different as having different roles. So here the two plumbers are essentially the crew that I labeled as homologous recombination. There's here a carpenter, which would be base excision repair, or BER, and then you can think the guy with the light bulb as NHEJ, or non-homologous end joining. But the name don't really matter. I just want to emphasize that there are many different systems in our cells that help repair the DNA, and they have different roles and different names. We need this because our DNA is constantly being disrupted in different ways. Just walking under the sunlight, for example, will create damages to our DNA, but also radiation, chemicals, or the normal division of our cells, maybe because we were growing or because we were repairing an injury, will introduce some errors in our DNA, and that's when those repair crews or those repair team come come to fix that. And the key here is that they all have different roles. So there are different types of of damage to our DNA, and these crews are specialized for them. So from left to right, you can see probably like me, essentially useless at anything but fixing a few light bulbs around the house. In the middle is a carpenter that have expertise in structure, and on the right here's a team of plumbers that very specialized to fix the plumbing, or even sometimes some gas pipes in the house. So turns out that in ovarian cancer, the HR crew, or the homologous recombination crew, can be out of service in about half of the patient. And when that happens, that's when we say that a cancer is homologous recombination deficient, or HRD, meaning the HR system is not working. And when that happens, it creates leaks. Obviously, in that analogy, you'd have problems with your DNA, and in the analogy of a home, you'd have some leaks and water damage. But if the plumbing team is not available for you, and you have maybe a family member that's a carpenter, on a pinch, a carpenter can probably help stabilize the leak situation. They'll probably come in and see it, and and sort the problem. And it may not be perfect, but it probably will help at least keep the situation stable. And this is exactly what happens in some cancer cells that have a deficiency of the homologous recombination system. And on its own, homologous recombination deficiency, or HRD, will support tumor evolution. However, and this is where it becomes important, it also creates a vulnerability to the tumor cells. And this is this is the situation when we can use very targeted treatment to be as effective as possible to kill the tumor cells. And what has evolved in the recent years is these new therapies that will actually do exactly that. They will inactivate another repair crew in tumors where the HR crew is already inactivated. And when that happens, then it becomes a disaster, because the alternative to the plumbing crew may be someone that has expertise in carpentry. But if there is no plumbing crew to help the leak, and no carpenter to maybe help stabilize the leak, well, you're left probably having me fix the leak at your home, and that's a terrible idea. It will not work. It will be a flood. It'll be water damage. And this analogy, in the cell, is that when both homologous recombination system and the BER system are out of service, the DNA becomes unstable, because there are no other good repair crews around to repair the damage, and the DNA becomes unstable, and then the tumor cell die. I think we'll go over this principle and with the other speakers, but I think this is at least one way to conceptualize the interaction between the homologous recombination system and its vulnerability to targeted treatment. Okay, so now I showed that in cancers that have homologous recombination deficiency, they're vulnerable to a specific treatment that will inactivate the alternative repair crew. So how do we now want to test for HRD? Well, there are two ways to test for HRD. One way is to assess if the members of the HR system, or if you wish, the plumbing crew, to assess if the members are healthy. So here, what we do practically is we'll look at genes like BRCA1 and BRCA2, which are the two most important members of the HR system. And if they are mutated or they show that they are not healthy, then we know that for sure the homologous recombination system is not going to work well, or otherwise we could say that the cancer is homologous recombination deficient. The other way to assess if the plumbing crew or the HR crew is functioning or not, it's by looking at it indirectly and to see if there are evidence that that there was no HR repair system to help repair the DNA. The analogy here would be me going to a home and see if there are leaks and see how the leaks were fixed. So maybe I go into a home and I see there are a few leaks here and there, and then when I look how they were fixed, I realize nothing was done to code, maybe. So that tells me that most likely there were no expert plumber around to fix the house. And so this second test is this second approach is similar to that. We assess for genomic scarring, which is changes in the DNA that let us know that the fixing was not done up to code. Now, practically, there are two tests to assess HRD. The first one is to look at BRCA1 and BRCA2 mutation directly. And so that is the direct way to assess for how functional the HR repair system is. And then the other approach is through HRD testing, which is not only includes a direct assessment of the BRCA1 and BRCA2 health status or mutation status, but it also looks at indirect approaches like genomic scarring, as well as sometimes other genes than BRCA1 and 2. Now, how do we interpret HRD results? You may have seen a report before, but there are different scenarios that will lead to different results. So the one scenario would be to detect that there is a mutation in BRCA1 or BRCA2. In other words, one of the two most important member of the HR system are not healthy. So they're not going, the system is definitely not going to work correctly. So we say when we find that, we say that the cancer is labeled as HRD, homologous recombination deficient. Sometimes, however, we do not find BRCA1 or BRCA2 mutation, but we find indirect evidence that the HR system is not functioning well. Like I was saying in the prior slide, sometimes this is referred to as genetic scarring. The other name for it actually is genomic instability score, but it refers to the same thing, an indirect assessment of the DNA that let us know that things were not repaired up to code. But if we find that, it also tells us that the cancer is homologous recombination deficient, or HRD. However, if no BRCA1 or BRCA2 are found, BRCA1 or 2 mutation are found, or there is low genetic scarring, the conclusion from that would be that the tumor is not homologous recombination deficient. In other words, the homologous recombination system is working normally, or likely working normally. Okay, Um, Here, I wanted to show this image to sort of give a bit of a perspective in ovarian epithelial cancers. Um, we have about 15% of ovarian epithelial cancer that have a BRCA1 and 2 mutation that is inherited or can be passed along to offsprings. There's about 25% of ovarian cancers that have a BRCA1 and 2 mutation, including inherited ones and sporadic ones. And by sporadic, we mean that the mutation cannot be transmitted to other family members. And finally, about 50% of all epithelial ovarian cancers are HRD. And I think this image nicely shows that if you were to only test BRCA1 and 2 in epithelial ovarian cancers, you would miss about half of the cases that have homologous recombination deficiency. And this highlights how the second test, which often referred as HRD testing, is more effective because it includes it detects a much broader uh, uh, breadth of HRD cancers. So, in conclusions, homologous recombination is an important system that repairs DNA in our normal cells. In some tubo-ovarian cancers, about half of them, homologous recombination can be inactivated because of genetic changes, and that's when we say that the tumor has homologous recombination deficiency. Tubo-ovarian cancers with HRD show vulnerability, or they can be killed with specific treatments. The HRD testing includes a combination of gene as well as an evaluation of genomic scarring um, or in other words, indirect evidence of function in the tumor DNA. Finally, HRD testing is more comprehensive testing than just performing BRCA1 and BRCA2 alone. And I think that with that said, I will gladly pass it along to my other colleague for the presentation. Thank you very much.
Thank you so much, Dr. Tessier-Cloutier, for that engaging overview of HRD. Your repair crew analogy for the different DNA repair pathways, it really made a complex topic so much clearer. So thank you for that. That was really interesting. Next, we will hear from Dr. Janice Kwon, who will speak to us more about understanding your HRD result. Dr. Kwon is professor and gynecologic oncologist at the University of British Columbia, Vancouver General Hospital, and BC Cancer in Vancouver. She completed her fellowship training at the University of Toronto and her master's degree in public health at Harvard and postdoctorate at the MD Anderson Cancer Center in Houston. She is the co-chair of the National BRCA Plus Collaborative in Canada, which is involved in education and advocacy around genetic testing and ovarian cancer prevention. Please join me in welcoming Dr. Kwon.
Thank you very much, Jessica, for that introduction, and to Ovarian Cancer Canada for the invitation to speak to all of you. I wish I could see you all in person, but another time. So the objectives of this presentation are as follows. What is HRD and how do clinicians explain it to patients? How does HRD fit in with other clinical factors? And finally, some common patient questions. Let's start with a crash course in genetics, although you've already heard that from my colleague. But let me just review the concept of homologous recombination repair. So this is a system involving several genes that code for proteins that repair DNA when it gets damaged from radiation or smoking or other things in the environment, or even cancer treatment. Every one of us has homologous recombination repair genes, which include commonly known genes like BRCA1 and BRCA2, PALB2, RAD51C, and D. Now, for most of us, these genes are normal and they work together to fix those breaks in DNA that occur all the time. But if we have a mutation in one of those genes, then that repair mechanism does not work properly. So if there is a problem with the homologous recombination repair mechanism, this leads to a phenomenon called genomic instability. There is some very sophisticated lab testing of the cancer cells to look for 3 markers that indicate that there is a problem with the homologous recombination repair mechanism. And you've heard this already, but the 3 markers are loss of heterozygosity, or LOH, which essentially means that a gene or some genes are missing. Telomere allelic imbalance, which is essentially a genetic sequence that's missing at the telomeric end of the chromosome, or really either end of the chromosome. And finally, large-scale transition, which means something large, greater than 10 megabases, is deleted or added. So the genetic code for DNA is made up of bases: adenine, cytosine, guanine, and thymine. So imagine 10 of those bases in a row, and then multiply that by 1 million, and that gives you 10 megabases. So that's the amount of DNA that's added or missing from this concept of large-scale transition. So then there's a score that's assigned to each of these 3 markers, and if that total score is more than 42, or at least 42, then we call that a high degree of genomic instability, or homologous recombination deficient, because the normal DNA repair processes are deficient. So to confuse things even further, we call that HRD positive. So it's homologous recombination deficient positive. Now, as you've just heard, 50% of ovarian cancer patients are HRD positive, which means that there's something wrong with the DNA repair mechanism in the ovarian cancer cells of 50% of patients. Now, if we look at the ones who are HRD positive, some are HRD positive because they have an inherited mutation in BRCA1 or 2. So when it's an inherited mutation, that mutation is present in all of the cells of the body. So it's present in blood cells and in cancer cells. That BRCA mutation is known to cause problems with DNA repair. But there are also some patients who have what's called a somatic BRCA mutation, or tumor BRCA mutation. That means that mutation is not inherited, but it develops in the cancer cells only. And it's something that's acquired during that individual's lifetime. They're not born with it. So in total, when you consider BRCA mutations that are germline, which means inherited, or tumor, something that they've acquired during their lifetime, that makes up 25% of all ovarian cancer patients. Now, another 25% of patients are HRD positive because of other genes that are involved in DNA repair. So why is it important to test for HRD in ovarian cancer patients? Well, because it can predict how well they will respond to treatment with a PARP inhibitor, which is given after they have finished their initial treatment with surgery and chemotherapy. So let's say you take 100 ovarian cancer patients and you test them all for HRD in the tumor. Then again, 50% will be HRD positive. That means that their DNA repair system is abnormal. And so their tumor cells or their cancer cells cannot repair the damage that's caused by cancer treatment, like chemotherapy or PARP inhibitors. So the tumor cells die, and that translates into the patient living longer. So I've put HRD positive patients in pink. So pink means positive. Now, on the other hand, the remaining 50% will be HRD negative, which means they don't have homologous recombination deficiency, or they're homologous recombination proficient, or HRD negative. That means that their DNA repair system is normal. So that may sound good, but that means that their cancer cells can repair the damage that's caused by cancer treatment. So if the cancer cells live because they can repair the DNA damage caused by cancer treatment, then they can metastasize, and that's worse for the patient. So this pathway is in neon green. So neon green means negative. Now we know that HRD status predicts outcome from PARP inhibitor treatment from some important research studies, and I think you'll learn more about this from the next presentation. Now this figure illustrates some survival outcomes from a large multi-center study called PRIMA. These are survival curves that show the proportion of individuals alive without evidence of cancer at certain time points. So just to draw your attention to 2 points, the graph on the left represents patients who are HRD positive, and the graph on the right represents ones who are HRD negative. So the higher the curve or the higher the line, the better the survival. So for patients who are HRD positive, they have a much better survival when treated with niraparib compared to not being treated with niraparib. And on average, that difference in survival is about 13 months. Now, for patients who are HRD negative, there is less difference between those who receive niraparib versus those who don't. On average, that difference in survival is about 3 months. So some patients who know they are HRD negative will actually decline to take niraparib because they don't think the additional 3 months is worth all of the side effects. But on the other hand, there are others who know that they are HRD negative who will choose to take niraparib because they feel that 3 months is better than nothing. Now, what if you don't know what your HRD status is? So if HRD testing is not available and you don't know the HRD status, then overall, there's about a 5.5 month difference in survival between those who take niraparib versus those who don't. But that's essentially the average of 50% of patients who are HRD positive and have a 13-month benefit, and the other 50% of patients who are HRD negative and have a 3-month benefit. So overall, how do clinicians explain this to patients? I think it would go something like this. HRD is a condition where cancer cells lose their ability to repair DNA. So it makes those cancer cells vulnerable to specific cancer treatments like PARP inhibitors. Mutations in homologous recombination or DNA repair genes like BRCA1 or BRCA2 can cause HRD or make a patient HRD positive so that those cells can't repair the damage that's caused by treatment and the cancer cells die. So this translates into longer survival. And then if they're HRD negative, they don't have homologous recombination deficiency, then their DNA repair mechanism is normal. And this means their cancer cells can repair the damage that's caused by their cancer treatment. So the cancer cells survive, and they possibly metastasize. And so here are some commonly asked questions that we get. Can the HRD test be wrong, or is it always positive or negative? Now, the HRD positive or negative result is based on a score, and essentially that score is on a spectrum from 0 to 100. So if the score is 0, then that means there's essentially nothing wrong with the homologous recombination repair mechanism. That means that the cancer cells can repair the DNA damage effectively. On the other hand, if the score is 100, then that's maximum disruption of the homologous recombination repair mechanism. Those cancer cells cannot repair DNA damage, so those tumor cells are more likely to die and the patient is more likely to survive longer. The most commonly used assay for HRD testing is called MyChoice, and the threshold or magic number for determining negative versus positive score is 42. So less than 42 is considered negative, and 42 or more is positive. But is someone with a score of 41 much different from someone who has a score of 43? Probably not, but one's considered negative and one's considered positive. And we know that there are patients who are classified as HRD negative who may actually have a good response to a PARP inhibitor. And we also know there's some patients who are classified as being HRD positive who do not have a good response to PARP inhibitors. So HRD testing is not 100% accurate or predictive of the outcome. Another question we get is, should everyone with ovarian cancer get HRD testing? And so I think the simple answer to this is no. Now, some patients already know that they have a BRCA mutation from earlier genetic testing. But if they don't have that information, the first test I think that should be done is testing on a sample of ovarian cancer tissue or tumor testing. And the first test that they should have done is tumor testing for a BRCA mutation. So again, from earlier in this talk, a BRCA mutation is going to be found in about 25% of ovarian cancer patients. Some of them are inherited and some of them are acquired in someone's lifetime. So if they have a BRCA mutation, they get a PARP inhibitor called olaparib. So I've put this pathway in pink. Again, pink is positive. And so a BRCA positive result means a PARP inhibitor, that's another P. But if the tumor is negative for a BRCA mutation, so that's the remaining 75% of ovarian cancer patients, then I think those patients are the ones who should have HRD testing. And so again, of those who undergo HRD testing, 50% are going to be positive. They're eligible, or they should be considered for niraparib because on average, they'll have a 13-month survival benefit compared to those who aren't treated with niraparib. And then the remaining 50% are HRD negative. And whether they go on niraparib or not, I think is a discussion between the patient and healthcare provider. So for patients who have a BRCA mutation in their tumor, they should have genetic testing done to see if that mutation is a germline mutation as opposed to one that's only in their tumor, because the tumor testing won't tell you if it's something that's acquired or something that's in all of the cells. Now, how do you get HRD testing in Canada? Now, HRD testing had to be outsourced to the States, but for a while it was paid for by the company that makes niraparib, but that funding ended. So the only province right now that pays for HRD testing for ovarian cancer patients is Saskatchewan. Patients in other provinces can have their tumor samples sent to Saskatchewan, but they have to pay for that testing. Now, the other way to get HRD testing is to have the sample sent to the States to have my choice CDX or Foundation 1 testing. And TSO is a kit that can be applied to ovarian cancer samples, and it uses the proprietary algorithm from my choice. And I know some institutions, including ours in Vancouver, are working on getting this TSO package locally. So in summary, homologous recombination deficiency, or HRD positive, means that the DNA repair mechanism is abnormal. 50% of ovarian cancers are HRD positive. BRCA testing on the tumor should be done first to determine eligibility for olaparib. And 25% of ovarian cancer patients will have a BRCA mutation in the tumor. Now, the remaining 75% should be eligible for HRD testing. Now, HRD testing on BRCA negative patients will help patients and clinicians to make decisions with respect to niraparib. So that brings me to the end of the presentation. Thank you for your attention, and I look forward to questions and discussion.
Thank you, Dr. Kwon, for walking us through how HRD results are discussed with patients and how they really fit in the broader clinical care, and as well as the importance of BRCA testing. I think that's a very important point. So I'm excited to introduce our next speaker, Dr. Melica Brodeur, who will dive deeper into how HRD and BRCA status inform PARP inhibitor treatment decisions in real-world care. Dr. Brodeur is an assistant professor in the departments of obstetrics and gynecology and oncology at McGill University, a gynecologic oncologist and a principal investigator at the Jewish General Hospital and Lady Davis Institute for Medical Research. Dr. Brodeur completed her medical degree at McGill University, followed by her obstetrics and gynecology residency at the University of British Columbia. She pursued a subspecialty in gynecologic oncology at the University of Montreal, completing a master's in biomedical sciences, and then a postdoctoral fellowship at Memorial Sloan Kettering Cancer Center. Her research focuses on understanding treatment response in gynecologic cancers and identifying new therapeutic targets and strategies to overcome therapy failure. Welcome, Dr. Brodeur.
Hi, everyone. Thank you so much for the invitation to speak tonight. I've previously presented at Ovarian Cancer Canada seminars, and I've really enjoyed the experience. So I hope that I can provide and share the knowledge that I know, and the speakers before me really set the stage and did all the heavy lifting. So my part of the presentation was really to cover how HRD influences treatment decisions. So we're going to cover these 3 points, and we'll finish off with a case presentation to kind of illustrate how HRD results can influence, or how HRD results can influence decision making. So how does HRD status influence the use and the decisions around PARP inhibitor? So as we've heard so far, HRD positive status is associated with improved survival with PARP inhibitor therapy. So we know this. And so for patients, this can help in their decision making when they're faced with, the known side effects that PARP inhibitors have, because all treatments have side effects. And so as you can see here in the slide, the HRD status can influence maintenance therapy choice, because those that have homologous recombination deficiency, or HRD positive because of a BRCA mutation, have the option of either going on olaparib for 2 years or niraparib for 3 years. Whereas those that do not have a BRCA mutation, but have a homologous recombination deficiency, have the option of niraparib only for 3 years. And so this matters because there are differences when receiving olaparib versus niraparib. So on the top left here, you've got the survival curves of the SOLO trial. The SOLO trial was the trial done for BRCA, for patients with BRCA mutated tumors, and using olaparib for 2 years. And the bottom right, this is what we call the PRIMA trial. This was the trial done for all-comer ovarian cancer patients, and included patients that were HRD positive, whether from a BRCA mutation or not, and also HRD negative or HR proficient, sort of synonyms. And so the ovarian cancers with BRCA mutations, as you can see here, the percentage from the SOLO trial, the percentage of patients without progression or recurrence of cancer at 5 years was 51% in this trial. And when in the PRIMA trial, when they broke it down by subgroups, so when they looked at those that had BRCA mutations only, those that didn't have a BRCA mutation but were HRD positive versus those that were HRD negative or HRP, you can see the breakdown of the survival of patients without progression or recurrence of disease at 5 years, and it starts at 37% with those that had BRCA mutations, and for those that had no HR deficiency was 8%. And so we know that the patients who have BRCA mutations have the best response to PARP inhibitor therapy and therefore the best survival. And so it is important to consider this, but also the fact that the side effect profiles for these two drugs are slightly different. And so overall, when we look at niraparib, which was used in the PRIMA trial in the bottom right figure here, niraparib had about 74% serious side effect rate versus olaparib, which was used in the trial in the top left here, had only 21% rate of serious side effects. And when we look at things like patients that needed dose interruptions or dose reductions, this was up to 80% in the PRIMA trial, the one with niraparib, versus 50% in the SOLO trial with olaparib. And so when we look at the different types of side effects, one of the more serious, but thankfully the less common side effect is development of a secondary cancer, in particular blood cancer. And so this is found in niraparib in about 2.5% of patients. And in the trial, it represented about 11 patients out of the 484 patients, versus those that didn't receive niraparib in this trial, the rate was 1.6%. And when we look in the SOLO 1 trial results, the equivalent numbers was 1% of patients had developed a blood cancer on olaparib, so that represented about 3 patients out of 260 patients, versus no patients had developed it in those that didn't receive olaparib. So the side effect profiles are slightly different. I don't think we can say that they're the same. And so when we're considering what the options are for patients that have a different HRD profile, it is important to consider that. We did look at real-world outcomes in our center at the Jewish General Hospital in terms of HRD testing inconclusive rates, which ranged about 9% at our center. I did see a report that was developed by GSK, who, as Dr. Kwon mentioned, was the industry that had at some point funded the HRD testing in Canada. They reported about 12 to 18%. So these aren't, they're not negligible numbers. So I think it is important to consider that it isn't a perfect test that always works. There is a certain percentage of patients that the reporting will come back inconclusive. And the other thing that's also important to consider is the delay to testing. So just because we request the test today, it doesn't mean we'll get the results tomorrow. And when we looked at our center, what we saw in terms of the delay from the time that we requested it to actually receiving the results was approximately 33 days. And this is excluding the time for obtaining the actual tissue. And so, as you know, as was previously mentioned, the BRCA1 and 2 testing on tissue remains the main reimbursed test in most Canadian centers. And so what happens if we don't have access to that? So currently, I can tell you what in our center, for example, what we're doing without HRD testing being reimbursed, we offer a few options. So one is to pay out of pocket, and so this is to perform any of the tests that were already previously mentioned. So either the Myriad genetics test or the Foundation test, or to send the test to Saskatchewan. These have slightly different price points. And so it is important to consider that as well, when making a decision as to what testing is best for the patient to do. Because some testing can hover around the 2,500 range, and some can be closer to $4,000 or $5,000. And the testing itself is one cost, but there's also the cost for actually retrieving the tissues that are archived in the pathology departments, and also the cutting that comes with the having to cut the tissues to be able to do the testing afterwards. Another alternative that has been proposed is, if really there's no other options, is to infer response to PARP inhibitor therapy. There's actually a booklet that the industry GSK, who created the niraparib drug, prepared, and so the main indirect way of inferring response to PARP inhibitor therapy was based mostly on chemotherapy response, and looking at the changes in that CA-125 blood test that patients often undergo, and seeing how that decline in the CA-125, whether it's very rapid or if there's a longer time for the decline in CA-125 levels. This can help infer the response to PARP inhibitor therapy, but of course it's not perfect. And so the next thing I wanted to do is kind of illustrate some of these points through a case presentation. And so and this is a real case. So we encountered a 48-year-old patient who had a history of breast cancer about 4 years ago. She also had a family history. Two of her sisters had breast cancer in the past as well. She presented to us with suspicious enlarged lymph nodes throughout her body, and also a small ovarian mass. And when the biopsy was done, it confirmed that she had high-grade serous ovarian cancer. And so she went on to have 4 cycles of what we call neoadjuvant chemotherapy, so upfront chemotherapy with the standard carboplatin and paclitaxel. And then she presented to us at the time that we were preparing to consent her for her interval debulking surgery. She presented with some shortness of breath. And so when we reviewed the CT scan that was done, sort of standard for pre-surgery analyses or preparation, we saw that actually in her scan there was some changes in her lungs. And so the radiologist had reported it as something called interstitial lung fibrosis. She went on to see a pulmonologist or a respirologist, and the lung function tests were quite abnormal. And the conclusion was that this was sort of a rare side effect from the carboplatin, and the recommendation from the pulmonologist had been not to undergo any further chemotherapy after the surgery that was planned. And so she did go on to have surgery, and had a great response to the chemotherapy. We could see there was very little residual disease left. She had her standard BRCA1 and 2 testing, which is done at our center, and it came back negative. She, in the meantime, in parallel, had what we call germline testing to search for any hereditary mutations, and there that we found a mutation in a gene called RAD51, which is one of the important homologous recombination genes that Dr. Tessier-Cloutier was referring to. But what was interesting in her case was that this gene mutation was actually found when the genetics team sort of looked at their database at this mutation, didn't find that it was in 2025 at that time associated with a sort of known significance in terms of its what this mutation means. Do we know if it's if it has an impact or not? And so but in the context of her family history, and some more investigation, the genetics team felt that even though this mutation currently is labeled as unknown significance, that it was likely what we call pathogenic, meaning it was a meaningful mutation. And so this kind of led us, we were left in a bit of a situation where we couldn't undergo like standard treatment, which was normally to continue with further chemotherapy. And we're faced with this germline testing for hereditary mutations that showed a suspicious mutation. And so when we had a discussion, a multidisciplinary team discussion, so pathologists, radiation oncologists, gyne oncologists, to discuss this case, the recommendation was to not continue with chemotherapy after surgery, as she had such a great response already with the 4 cycles and very little disease left at the time of surgery, and to instead offer her niraparib, so a PARP inhibitor therapy after her surgery. She did encounter the side effects, as I mentioned earlier. Most patients do end up having some side effects. So in her case, initially her platelets, one of the type of blood cells, did drop, and so there had to be some adjustments that were made. But she eventually sort of stabilized, and so far she's been on this treatment for 6 months, and without any evidence of recurrence. She is still recovering from the fibrosis that was discovered from the chemotherapy, so that's something that's still ongoing, which I guess kind of highlights to the fact that treatments don't come without side effects. So it is always important to consider that. And so with that example, I'm going to end my presentation and thank you for your attention, and be happy to take any questions that I can help answer.
Wonderful. Thank you so much, Dr. Brodeur, for those important clinical insights into PARP inhibitor treatment, and really for sharing that real world case example. I think that illustrates how it's really personalized for each individual patient. Next, I'm pleased to introduce Alexandria Tadman, the Government Relations and Advocacy Lead at Ovarian Cancer Canada, who will discuss HRD testing access and equity across Canada. She has been leading and advancing advocacy efforts since 2022. And prior to joining Ovarian Cancer Canada, she spent 5 years with the Ontario provincial government, including as a senior policy advisor at the Ministry of Health. With a strong foundation in the not-for-profit sector, both in Canada and internationally, and a joint master's degree, Alexandria brings a wealth of experience in health policy and system change. Welcome, Alexandria.
Thank you so much for that introduction, and to all of you for joining us on this webinar. So first, I want to highlight the national landscape of HRD testing access. As Dr. Kwon said, at present, HRD testing is publicly funded in only one province, Saskatchewan. In other provinces, there is a lack of clarity on publicly funded testing availability, and one way that OCC learns about testing is through our patient community. So for example, we have heard from patients in Nova Scotia that they have received HRD testing, but there's no public-facing information or confirmation by government that this is happening and that they are providing the funding. So when OCC is armed, with this information, it really supports our advocacy for testing access, and it allows us to ask more informed questions when we send letters or have meetings with decision makers. It really helps to have that information, and it's essential to supporting our advocacy in this space. One point I'll make just before I move on to the next slide is that having only one known and confirmed province publicly funding HRD testing, with some knowledge of other provinces that may be sending samples, this creates inequitable access to care, where a patient's ability to receive evidence-based treatment depends on their postal code rather than medical need, which is unacceptable. So funding HRD testing in every province would ensure more consistent, fair, and patient-centered care across the healthcare system, which is definitely a priority of ours. If you have received HRD testing in your province and you'd like to share that with us, please reach out. My contact information will be shared on the screen at the end of the presentation. Oops, there we go. So as mentioned on the previous slide, patients' voices play a significant role in shaping access to care, treatments, research, policy. This slide shows just a few examples of how patient voices have moved the system forward in drug access, prevention, and expanding services. We hear from patients through dialogue, TLTs, direct reach outs to our staff, and through that, we collect quotes, testimonials, we schedule committee appearances, we participate in opportunities to present to decision makers. The list sort of goes on and on. But again, I just really want to emphasize the vital role that you play. So next, I'm going to outline OCC's HRD advocacy to date and how we're working with the clinical community to advocate for testing access with provincial governments. So as you'll see on the slide here, we work closely with clinicians. This is one of our strengths as a patient organization. And in this case, it is a common goal of ours with clinicians to have patients access HRD testing nationally. We've done different engagements through presentations and discussions at clinical conferences. We participated in a HRD business case, and we've been meeting with pathologists to inform our advocacy to see how we can support each other's efforts towards this shared goal. I also want to note that our ongoing work with clinicians, the GOC, goes beyond HRD testing, and we also discuss and look at other biomarkers. In January 2026, we sent a letter to each province and informing them that HRD testing is a critical tool that helps guide patients regarding the use of targeted therapies, strongly urging their government to fund HRD testing for patients. And we made clear that this investment would empower clinicians to identify those most likely to experience meaningful benefit from targeted therapies, and that it would also equip patients with the information that they need to make decisions that align with their personal priorities. The responses that we will receive from governments will inform our work and our next steps. And then we will continue to engage with government, clinicians, and patients to continue to move this request forward. So I will stop there, but I do want to encourage you to get involved with OCC's programs, attend TLTs, have conversations with OCC staff or a politician at the walk, post your questions or share your experiences on Dialogue, have a support call with our programs team, or sign up for our newsletter. These are the best ways to stay updated and engaged. Thank you.
Thank you, Alexandria, for really highlighting how patient voices are driving Ovarian Cancer Canada's advocacy work to improve not only HRD testing and just talking a little bit more about our program. So thank you for sharing all that. Before we open the floor for questions, I'd also like to invite my colleague, Dr. Allison Ross, our Director of Knowledge Mobilization, to share the patient HRD resource that was developed to accompany this webinar. So I just see she's come on now.
Thank you, Jessica. So I'm just going to be here for just a moment, and I'm going to put a link in the chat. I'm really happy to be here to share our latest patient education resource guide. And this one is specific to HRD testing. So I'm just going to, I put the link in the chat so anyone can access it and download it themselves. And I'll just share my screen so we can all look together. Okay. So this is just a 2-page guide. We understand that all of this can be really difficult to remember and get your head around, especially if your background isn't in science or healthcare. So we've taken some time to really try to break down that science, that scientific information for you in a way that's going to be hopefully understandable and accessible for everyone. So the front page of this patient guide really just tries to, in very simple language, explain what HRD is and its relationship to ovarian cancer. The bottom of the first page really tries to break down the relationship between HRD and genetic mutations. And on the second page here, we have some questions that you might want to consider asking your oncologist about HRD testing. So that's all I wanted to share for now. So again, the link is there in the chat if you would like to download. And then I also want to make sure that people feel that they can reach out and share any feedback they might have about the guide. So I'm putting my email address in the chat now. So if you access this patient guide and you have any comments or thoughts from me, please don't hesitate to reach out, and I'd be more than happy to hear from you. Okay, I was promising to keep it short, so thank you, Jessica.
Thank you so much, Ali. Now we'll move on to your questions. So if you do have a question for any of our speakers, please enter it into the Q&A box. I see some have already come in, and we will do our best to get to as many as we can. So I'd like to invite our speakers just back on camera if possible for the questions. Wonderful. I'm just gonna see. Okay, perfect. So I actually have just a general question, and maybe this is more Alexandra asked actually. So why isn't HRD testing available nationwide for free? I know you spoke a little bit about it, or I guess maybe the better question is, like, we know there's access differences between provinces, but what can we do to reduce those differences would be maybe another way to reframe it.
Yeah, I can answer both. So for why isn't testing available nationwide? So it's a great question. The Canadian health system is very complex, and each province and territory can make their own decisions about, what they do and do not fund in their system. And unfortunately, as a result, you have tests that are funded and available in some provinces and territories and not in others. This is why, advocating for this coverage is so important. And for HRD specifically, because it isn't a requirement to get tested to have access to a drug, it didn't get stewarded through the funding approval process. So that's kind of the first part. And for what can be done to reduce this, so again, specifically for HRD testing, the most important step to reducing those differences is having governments fund the test. So the test is available to patients in every province. That's a key focus of ours right now, alongside other biomarkers, because one of our main advocacy priorities is improving access to treatments and making sure patients and caregivers have the information that they need to make informed decisions about their care. So yeah, thank you for those questions. I think it's helpful information for the whole group to have.
Thank you for explaining that, Alexandria. I do have a question for Melica, Dr. Brodeur. Why are different PARP inhibitors being used in the maintenance treatment of BRCA positive and BRCA negative but HRD positive patients? And will olaparib ever be offered for HRD negative patients?
That's a great question. Fortunately or unfortunately, we're kind of a little bit at the mercy of what clinical trials have been conducted, which is, and based on those trials is how approvals are made afterwards, right? So as Alexandria mentioned, the healthcare system is very complex, and sometimes it even for those that are in that field, it, don't always understand how decisions are made. But what is quite certain is that we do make a lot of the decisions primarily based on clinical trials. And so olaparib in ovarian cancer was tested in patients who had BRCA mutations in their tumor. And so that is where the approvals are. Now, sometimes we see that the same drug can be used in different cancer types and approvals can be different. And that's sort of unfortunately just, because of the way that clinical trials were designed. So the short answer is because that's how the clinical trial was designed. Now, is there at any point going to be, an olaparib study in HRD patients? I haven't heard of anything unless Dr. Kwon has heard something or Dr. Tessier-Cloutier, but I haven't heard about anything. And so we're kind of in some ways for the HRD positive, but not BRCA mutated ovarian cancer patients, we're kind of, I guess, for lack of a better word, stuck with niraparib. Yeah.
Thanks for explaining that a little more in depth. So the next question is actually for Basile. How does BRCA methylation affect the HRD score?
Oh, that's a very advanced question that you had for me. So methylation is one of these genetic changes that inactivate certain genes. More commonly, we hear about mutations, right? That's when we have a break actually into the DNA. However, methylation is a different is a completely different mechanism, and that instead of making a break into the DNA, it silences the DNA, so it kind of shushes that area of the DNA where the gene is, and but the final result is the same. So to answer your question, yes, if you have silencing of BRCA1 or BRCA2 through methylation, you could have a homologous recombination deficiency in the tumor cells. Yes.
Great, thank you for explaining that. Yeah, I was that was interesting that question came up. So thank you for whoever posted that one. Janice, is HRD testing used at recurrence as well?
Yeah, that's a really good question as well. I would say that it used to be used more commonly in the recurrent setting before the evidence came out for the PARP inhibitors in the first line maintenance setting. So our experience in BC is that when patients use a PARP inhibitor after they've completed first line treatment, so they've had their surgery, they finished chemotherapy, and then they go on niraparib, then they wouldn't be eligible to go on a PARP inhibitor again if they happen to have the disease come back in the future. So we used to use PARP inhibitors more, I would say, in the second line setting or recurrent setting, but now it's being used more in the first line setting. And if they use it after they've completed their initial treatment, then they can't get it again.
Great. Thank you for explaining that. Another clinical question, maybe Melica, you can answer this one. Are there any known benefits for being HRD positive? Do you anticipate anything coming kind of up the pipeline?
So to answer the first part, it's a great question. So we do know that patients who have evidence of HRD, half of them being related to BRCA mutations, do tend to have good responses to the treatments that are currently offered. So that includes platinum-based chemotherapies and PARP inhibitor therapies. And so as a result of that good response and also durable response, these patients tend to have good survival or longer survival. So that answers that part of the question. And your second part was about anything coming up in the pipeline for patients that have evidence of HR deficiency.
Or I think any like new drugs coming in
new drugs
specifically for HRD positive.
So there have been some trials that have been done looking at other types of ways to target the whole, the crew, if you want, of DNA repair genes, gene mutations. And so there have been a lot of studies, but I would say that compared to the PARP inhibitor studies, nothing has yet stand out enough to the point that, going towards approval. There have been some changes in standard of care in ovarian cancer, but not specifically related to HRD status.
Okay, thanks. That does clarify things. Thank you. I think this might be for Alexandria or Basile. What might the timeline be for local HRD testing to be, available in each Canadian province? So we said that only Saskatchewan has it publicly funded right now, but do you see a timeline? Or
I
can you
can,
share?
I can speak for Quebec, where I practice. There's no firm deadline, but we validated the test, so the test is working locally. We can test it, but we're just waiting for the approval from the government for it to be reimbursed. So we're kind of all like buzzing around and putting pressure on the government so that they can let us use the test. But I think this is actually it's for us. It should happen very soon in the next couple of months. I hope to have signs of a development there, but right now nothing confirmed, unfortunately.
And I can add to that a little, speaking about the other provinces and territories as well. But as I mentioned, we're working with clinicians and pathologists on the access issue, and advocacy continues. But yeah, just to echo your comment, there is no indication that this is going to happen quickly. And unfortunately, we don't have set dates or deadlines that we can share. We wish that we did. We want them as well. But yeah, like I said, I think one of the best things to do now would be to sign up for our newsletter, get engaged with our community online, and then as soon as we have information that we can share, we will share it.
Thank you. Yes, that's a good point. Thank you so much for pointing that out, Alexandria. I have another one for Janice. What is the longest period of time within Canada that patients can be on a PARP inhibitor, and why?
Oh, that's a great question. The landmark trial that showed the significant benefit with olaparib in patients with a BRCA mutation, that drug was to be used for 2 years, and so that's been adopted as policy, and I would imagine all jurisdictions in Canada that have olaparib available. We do know that there are individuals who respond really well to olaparib and they tolerate it really well. And when that 2-year deadline comes up, they're a little bit nervous to stop taking the olaparib when it's kept the cancer in remission and they've been tolerating it really well. So I do know that there are a number of individuals who have chosen to take olaparib for more than 2 years. I don't know what the maximum amount of time is that someone has taken olaparib, but I know that there are some who continue to take it until there's evidence of a relapse. And that can be for many more years than the initial 2.
So in your experience, it's really a conversation that you have with the patient and kind of
Yes.
something you decide together. Okay, thank you.
Yes.
Melica, do you have anything else to kind of add from the Quebec perspective or also as a gynecologic oncologist?
Yeah, it's a great question, and it's a question I ask myself very often. It's very challenging. Like as Dr. Kwon mentioned, it's for the patients that do tolerate it well, because I did mention that there was a lot of side effects, but there are patients that don't have really any side effects and are quite well on it. And their cancer, is at bay when they get to the 2-year mark, or I guess in Iraq, the 3-year mark. And it's very, 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 very tough, to get off a drug that you feel has kept you in remission. Even though we know about the side effects, including the scary one that I mentioned, which is the blood cancer risk. And so it is a conversation between the patient and the multidisciplinary team taking care of the patient. But I think in the era of precision oncology, which I think is a term that people are starting to hear more and more about, this concept of, a one size fits all, everyone gets 2 years or 3 years, doesn't really work anymore. I think that we do need to start individualizing PARP inhibitor treatment periods, or actually any kind of maintenance therapy, needs to be better tailored for patients. It is something that in the research space we are working on, and so we hope that that will eventually be incorporated in clinical trials of maintenance therapy. It wasn't in the trials that were done, but hopefully soon. It is something that is on our priority research-wise that we can hopefully get into the clinic soon.
Thank you. And could you also just reiterate what the side effects were? That was one of the questions as well. Like kind of contrast the olaparib versus niraparib side effects, if you don't mind.
For sure, yeah. So one of them is the general percentage of the serious side effects. So side effects are graded 1 to 5, 5 being really, really bad, 5 is death. But you know, the serious ones is grade 3, 4, and 5. And so when you look at the overall percentage, niraparib has a much higher percentage of serious side effects compared to olaparib. So there's that. But when you look at the individual side effects, you know, when you look at the changes in or the drops in blood cells, so red blood cells, platelets, white blood cells, that is found in in a higher proportion of patients that go on niraparib versus olaparib. I mentioned also the scary but not common side effect, which is the secondary blood cancer. That also was found more in patients on the niraparib treatment. And so it is important to know that difference, particularly for patients who have the choice, who have a BRCA mutation. They do have a choice of one or the other. And so I think this is an important thing to consider. For patients that are HRD but not BRCA, unfortunately, there isn't a choice. Niraparib is the only one that's approved. And then it's particularly important for the patients that don't have evidence of HR deficiency, so who are HR proficient. I think it's even more important to understand that, because when we look at in the trials, you know, what the survival benefits are compared to the side effect profile. This is where, you know, I think the side effect profile for most patients compared to the minimal clinical benefit with the drug plays a big role in decision to even go on PARP inhibitor maintenance therapy. But there is a very long list of side effects. I won't go through them right
Yes.
now. I think it'll be very long, but there is an extensive list. Yeah.
Yes, and those would be discussed obviously with the patient at the time of their decision. So thank you for that. And then Basile, there's a question here about, is there any information on like if any other companies are developing HRD test kits that eventually would be cheaper than like the Myriad and all of I think the other
Yeah.
thing.
That's a really good question. You know, there are different there's certainly different other companies that make HRD testing. They all slightly different. But you know, I think currently the one that's most cost efficient is the one that's being provided or being at least set up now in Canada in most centers, like the one in Saskatchewan. That's currently available. The one that in BC is being also worked on, and the same in Quebec. It's a combination of a test that was how should I say that? It uses a large sequencing panel, so a test that looks at multiple genes, like over 500 genes, and using the information that the test collects from those 500 genes, we can infer what the HRD status is. So it's a clever way, using some algorithm that are proprietary to the Myriad My Choice test, to kind of combine more than one function in one. But there's no because of the I guess the challenging nature of HRD is it's like I was saying earlier, it's a genetic scarring that we look for. So it's like clues that we look for that tells us that the HR system is not working well. So to assess for these clues, we have to look at large areas of the DNA. So we cannot just have a simple targeted test that would be cheap, and so we're left having to do a lot of to test broad areas of the DNA, and that's what's expensive. So so far no easy cheap workaround.
Thank you for clarifying that. I think we have time for one more question, so I'm gonna open this to the full panel. What's one thing you wish that every patient understood about their HRD results? And maybe we can start with Melica or Janice, and then anyone else.
Sure, yeah, I could go. I mean, I think for patients that are able to get HRD testing, I think the first thing to know, and I kind of alluded that during my presentation, is that at the end of the day, it remains a test that has its limitations, and there are limitations that are, you know, can be put into different buckets. There are technical limitations of the actual test itself, you know, things of like, you know, how the sample quality that goes into the actual testing that's done, and then all the way to the interpretation of the results. And so it isn't a perfect test to predict perfectly how the response to PARP inhibitor therapy will be. There are some patients that are predicted to respond very good. You know, let's take an example of a patient that has a BRCA mutation and should respond very well, but then, you know, doesn't. And so you're left, you know, patients might be left trying to understand that. Versus the other way around, a patient who was labeled as HRD negative or HR proficient, and for whatever personal choice chose to accept the maintenance PARP inhibitor therapy and did have a good response or a durable response to it, and you know, when that wasn't expected. So I think there's that part that I think needs to be sort of understood and discussed, is that it isn't a perfect test. It's a way to infer response to PARP inhibitor therapy, but it isn't a perfect. It has its limitations. So I would say that's one thing that I would think is important as a takeaway from HRD testing.
That's a great point. Anyone else would like to answer?
I may just say quickly, I agree with Dr. Brodeur. I wanted to say sometimes the test comes inconclusive. We've said that earlier as well. And you know, when the test comes back inconclusive, there may be alternative to retest either on another sample, maybe from a prior biopsy or a prior specimen, and so there may be ways to get a definite results. And often the tests become the reason why HRD tests becoming inconclusive is possibly that the amount of tumor tissue on the sample that was sent for the testing may have been lower, and makes it more difficult for the test to be certain.
Yes, that's also a very good point. Thank you.
I don't have much to add to what my colleagues just said. I agree completely, and I did allude to this in my presentation, that HRD testing is not a perfect test. It's not 100% accurate. It's not a black and white answer. And again, we've all had patients who may have a low HRD score, so they're considered HRD negative, but they may respond well. And then on the other hand, we have those who are HRD positive and they don't respond as well as we thought that they would. But I think the important thing about HRD testing, and the reason why I really believe it should be available to all ovarian cancer patients, is that it empowers these patients to make decisions about their treatment, especially if they have an HRD negative result, when the magnitude of benefit from the PARP inhibitor may not be as favorable as we'd like. And so it gives them the information to be able to make that decision, whether they will choose to to go on the PARP inhibitor or not. And in the absence of that information from the HRD testing, it's hard to make that decision.
Yes, and that is a really important key takeaway from this webinar, and I think a great point to end on. So I just want to take a moment to thank our incredible panel, Dr. Tessier-Cloutier, Dr. Kwon, Dr. Brodeur, Alexandria. Thank you for being here. Thank you for sharing your expertise with us. And thank you to all our participants for joining us and engaging in this really important conversation